Good afternoon, our dear students. I'm glad to see you one more time, and one more time today I have a lecture for fourth year students, English speaking, but now it is a topic for groups, for groups of fourth year who had a second or eighth semester. And I remind you that it is in the end of this semester you have an exam with a mark from internal medicine with endocrinology from the 7th and 8th semester. Topic of our today's lecture, I remind you that we continue hematology. Previous lecture you had about anemias, and now it is acute and chronic leukemia. Plan of our today's lecture, it is general overview of leukemias, what is that and what types of leukemias we have and what's the main difference between them. It's acute, myelogenous, lymphoblastic, chronic, myelogenous, and lymphocytic. We will discuss what is that and what the difference between them. And list in the end of the lecture, it will be a list of abbreviation and diagnostic guidelines for you. Let's give definition. Leukemia. It is a group of progressive malignant neoplasms, cancers of the blood-forming organs, marked by diffuse replacement of the bone marrow, development of leukocytes and their precursors in the blood and bone marrow, accompanied by reduced number of erythrocytes and blood platelets, and resulting in anemia, increased susceptibility to infection and hemorrhage, with weakness and malaise, fever, pain in the joints and bones, swelling of the lymph nodes, spleen and liver. Let's discuss epidemiology. Here you see a scheme of estimated age standardized incident of mortality rates in general in all whole world epidemiology. And you see in both sexes mortality rate, I mean oncology, malignancy, in structure of main disorders you see leukemia, it connected with both sexes, with all ages, yes, and in a structure of incidence on onco disorders and mortality from the cancer, it takes maybe 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. 13 place in all mortality level in cancer structure. And as I told, it can be two types, two big groups of leukemias, and it is acute and chronic. And two another big groups, it is lymphogenous and myelogenous. Acute leukemia in general, what is it? Chronic exposure of certain chemicals, for example benzene, can be a risk factor for this group. Long-term treatment with alkylating substances and ionizing radiation. Mutations in cellular oncogenes, tumor suppressor genes, and transcription factors. Risk factors for chronic leukemia include sex. Rate man-woman is nearly 2 to 1. Men twice more often suffer from chronic leukemia than women. And genetic factors. First-degree relatives of patients have a more than 3 times greater chance to develop leukemia. Another risk factor for chronic, it is East Asian region. They are more sensitive group for these disorders. And certain retroviruses, some rare cases of T-cell leukemia are associated with infection of human retrovirus, like HTLV1. Etiology. In almost all cases, etiology is unknown. As usual in oncology, in cancers, we almost in all cases we can't say what exact cause lead to this cancer. Different kinds of leukemia are believed to have different causes. Abnormalities of chromosomes have been found in various types of leukemia. Whatever chromosomal alterations are primarily or secondary is undetermined, but they are at least contributory in the development of leukemia. There is an increasing body of evidence incriminating viruses in leukogenesis in men, and they may be factor of all cases. Certain chemicals and ionizing radiation may be important etiological factors in a few cases. Classification. 4 major kinds of leukemia. I told you that 2 big groups, acute and chronic, and 2 big groups, myelogenous and lymphocytic. It is, if it is acute and myelogenous, we name it acute myelogenous leukemia, or AML, or myeloblastic. If it is chronic myelogenous leukemia, we name it CML, or chronic myelogenous leukemia. In case of acute lymphocytic, we name it acute lymphoblastic leukemia. It connects to blasts that are the main cells in these disorders, acute lymphoblastic leukemia, or ALL. And if it is chronic lymphocytic, we name it chronic lymphocytic leukemia, or CLL. And let's discuss all of these cases separately. Acute myelogenous leukemia. Let's give definition. Acute myelogenous leukemia, or myeloid or non-lymphocytic, represents a group of clonal hematopoietic stem cell disorders in which both block indifferentiation and unchecked proliferation result in the accumulation of myeloblasts and the expense of normal hematopoietic precursors. Epidemiology. Acute myelogenous leukemia is the most common acute leukemia affecting adults, and its incidence increases with age. On this scheme, you see that age people much more often suffer from this disorder than younger people. World Health Organization classification. It is acute myelogenous leukemia with certain genetic abnormalities, with myelodysplasia-related changes, AML related to previous chemotherapy or radiation, AML not otherwise specified, myeloid sarcoma or granulocytic sarcoma or chloroma. It is myeloid proliferation related to Down syndrome and undifferentiated and B-phenotypic acute leukemias. It is a main forms. Clinical presentation of acute myelogenous leukemia. Initial clinical presentations are related to pancytopenia, the reduction of all cells counts, reflecting in leukemic cell replacement of bone marrow, and include headache or disorientation due to abnormal white blood cells infiltrating the central nervous system. It can include anemia, which accompanied by pallor, fatigue, malaise, hypoxia, and bleeding, caused by rapidly proliferating leukocytes inhibiting formation of erythrocytes and thrombocytes. When it is overproduction of leukocytes, it is expressed growth of leukocytic cells. Can be suppression of erythrocytes and thrombocyte growth. Infections, for example, pneumonia, mouth through ulcerations caused by increased numbers of immature and abnormal leukocytes which are unable to fight off infections. It can be increased metabolic rate with weakness, pallor, and weight loss caused by increased leukocyte production which require increased nutrient production. Hyperuricemia, which may lead to renal pain, obstruction, and infection caused by a great number of leukocytes being destroyed, which releases large amounts of uric acid. In late stages, leukocytes infiltrate the kidneys. Enlarged organ like spleen and liver caused by increased number of white blood cells accumulating with the liver and spleen causing tissue distension. Lymphadenopathy and bone pain caused by excessive number of white blood cells accumulating in lymph nodes and bone marrow. Bone discomfort, especially in ribs, sternum, and tibia. Older adults may experience delirium and progressive weakness. Here you see pictures with different examples of presentation, clinical presentation of acute myelogenous leukemia. You see here like unexplained bruising, paleness of skin, and possible petechia. Here you see severe generalized gingival overgrowth with localized necrosis and sloughing involving in the interdental papilla. Acute myeloid leukemia or myelogenous leukemia, you see schematically the main presentations, what we pay attention one more time during physical examination. It is bleeding gums, fever even when infection can't be identified, night sweats, weight loss, bone pain, bruising, blood in stools, itching, persistent infection, fatiguing, and breathlessness. Diagnostics of acute myelogenous leukemia. First of all, as usual, it includes history and physical examination of patients with finding all these symptoms. In additional tests, blood test, we usually find leukocytosis, sometimes leukemic blasts. What is most typical for acute myelogenous leukemia? It is leukemic blasts. In general, blasts is the main important differentiation. A big number of blast cells, the main sign of acute leukemia. It can be isolated decreases in platelets, red blood cells, or even with a low white blood cells count, what we named leukopenia. Bone marrow biopsy and aspiration to diagnose the presence of leukemia to differentiate AML from other types of leukemia. Immunophenotyping to determine a subtype of AML by comparing the cancer cells to normal cells in the immune system. Here you see microscopically how looks malignant myeloid cells. And in such way, it usually look result of immunophenotyping. Yes, when the different type of cells in a different degree of progression colored by different color. And you see here in green myeloblast, monocytoid cells, blue color, violet monocytes 2, and young cells in red. And according to the distribution, we can understand is it present leukemia and what the type of leukemia. Treatment. There are 4 types of standard treatment of acute myelogenous leukemia. First type, it is chemotherapy. It systemic. It have to be intrathecal, the spinal canal with subarachnoid space, or regional drugs. Usage depend of AML subtype. Second way, we can use radiation. Third way, it is stem cell transplant. And fourth, it is targeted therapy with monoclonal antibodies or other substances to destroy specific cancer cells without harming the patient's normal cells. The primary treatment which we use for the most patients, it is chemotherapy. It includes 3 phases. First one, the induction phase, clears the blood of leukemia cells and reduces the number of blasts in the bone marrow. Second, or consolidation phase. It administered after the rest period where the patient recovers from the first phase with the goal to kill the leukemia cells and are still present. And third, or maintenance phase, it is necessary in only certain types of leukemia and includes giving low doses of chemo drug for months or years after consolidation phase. Prognosis of acute myelogenous leukemia. Acute myeloid leukemia is a curable disease, and the chance of cure for specific patient depends on number of prognostic factors. Increasing age is the adverse factor because older patients more frequently have previous antecedent hematologic disorder along with comorbid medical conditions that compromise the ability to give full doses of chemotherapy. A previous antecedent hematologic disorder is associated with poor outcome to therapy. Next, leukemia, it is acute, but if it was myeloblastic, here is lymphoblastic leukemia. Let's give definition. Acute lymphoblastic or lymphocytic or lymphoid leukemia, ALL abbreviation, represents a group of clonal hematopoietic stem cells disorders in which both a block in differentiation and unchecked proliferation result in the accumulation of lymphoblasts at the expense of normal hematopoietic precursors. Here is a scheme of the incidence of acute lymphoblastic leukemia by the age, and you see if myeloblastic was more typical for aged people. Here the peak of incidence of acute lymphoblastic leukemia, it is children. Unfortunately, children more often suffer from this type of leukemia. It decreased till adult, risk decreased till adult age, and in aged people it one more time a little bit increased, but the most that age that in the most risk, it is children from 5 till 10 years. World Health Organization classify acute lymphoblastic leukemia in B cells lymphoblastic leukemia, lymphoma not otherwise specified, and B cells lymphoblastic leukemia or lymphoma with recurrent genetic abnormalities, and classify these specific genetic abnormalities. Clinical presentation of acute lymphoblastic leukemia include anemia, dizziness, weakness, fatigue, shortness of breath, frequent or unexplained fever and infection, weight loss and loss of appetite, bleeding from the gums or nose, and pale skin. Moreover, we can see in such patients excessive and unexplained bruising due to low platelet levels, swollen lymph nodes, and most often we can find it during objective examination on neck, underarm, groin, stomach, bone pain, joint pain, the spread of blood cells from the marrow cavity, pitting edema like swelling in the lower limbs and abdomen. Here, one of the most bright and often symptoms, it is unexplained bruising, it is paleness of skin, and petechia. They are nearly the same with acute myeloblastic leukemia. And the same generalized gingival overgrowth. It is the same picture, it's possible for lymphoblastic too. Diagnosis. It is history and physical examination too. In blood test, we find leukocytosis, but here it is due to lymphoblasts. Isolated decreases in platelets, red blood cells, and even with low white blood cells. It can be leukopenia relatively to lymphocytosis. In bone marrow biopsy and aspiration, the presence of leukemia, differentiation of acute lymphoblastic leukemia from the other types of leukemia. We find a lot of lymphoblasts. In immunophenotyping, to determine the substance of ALL by comparing the cancer cells to the normal cells in the immune system. Here are the microscopic changes, and here you see by the arrow malignant lymphoblastic cells. And immunophenotyping in patient with acute lymphoblastic leukemia look like this. You remember picture from the acute myeloblastic leukemia. Treatment of acute lymphoblastic leukemia, if there was 3 phases, here are 4 phases. First phase, it is induction too. Induction therapy here with the purpose to achieve remission by killing most of the cancer cells. Second phase, it is consolidation, the same with previous scheme, or post-remission therapy with the goal to destroy any remaining leukemia cells in the central nervous system. It usually lasts for 4 to 8 weeks. Third phase, it is maintains a phase with a low-dose therapy is given to prevent cancer cells regrowth. Usually we use it for 4 weeks, and here for acute lymphoblastic leukemia we have phase 4. It is preventive therapy to the spinal cord. It is chemotherapy drugs are injected directly into the spinal cord fluid. Four main types of specific treatments of acute leukoblastic leukemia include chemotherapy to kill all any leukemia cells that may have spread to brain and spinal cord. We discussed the phase in previous slide. Moreover, it can include targeted drug therapy to attack specific abnormalities that cause a cancer cell growth. Next, it is radiation therapy is typically used when the cancer has spread to the central nervous system. Stem cell transplant may be used for patients at risk of currently going through a relapse. Physical therapy and exercise take its important place in the treatment of acute lymphoblastic leukemia, and it usually includes up to 15 minutes of walking at least 5 times per week. It is strength training combined with aerobic exercises 3 times per week, twice daily for 30 minutes. It is pain management or transcutaneous electrical nerve stimulation, for example, or hot packs or cold packs or massage, etc., and other ways of management of pain. And stretching. It is sustained stretch, active and passive range of motion, and splitting. Medications. For chemotherapy, we usually use L-asparginase and vincristine. We usually add to our treatment steroids like dexamethasone and hydrocortisone, drugs for high-risk patients like daunorubicin and cytarabine, and other drugs like methotrexate, 6-mercaptopurine. And novel guidelines, novel approaches can include such drugs like the proteasome in combinations with therapy and chimeric antigen receptors. Prognosis of acute lymphoblastic leukemia. It is a curable disease, and the chance of cure for specific patient depends on number, as usual, like in previous type, depends on prognostic factors. A 5-year survival rate has improved from 6 decades ago to 85% currently, largely because of clinical trials on new chemotherapeutic agents and improvements in SCT technology. Next type, it is chronic myelogenous leukemia. Let's give definition. Chronic myelogenous leukemia or myeloid or myelocytic or granulocytic leukemia is a clonal hematopoietic stem cell disorder with an abnormal increase in mature and immature granulocytes as neutrophils, eosinophils, and myelocytes, especially in bone marrow and blood. That occurs especially in adults and that is associated with the presence of Philadelphia chromosome. Incidence of chronic myelogenous leukemia epidemiology, you see that increase with the age and reach its peak in age nearly 65-75. You see that this the typical prognostically risk factor and maybe even etiology of chronic myelogenous leukemia. It is presence of Philadelphia chromosome, and you see how it looks like from the normal chromosome 22, it goes some part of chromosome 22 and go somewhat from chromosome 9, and they're mixed in opposite positions. That part of chromosome 22 goes to 9 and from 9 to 22. And this changed chromosome 22 with the part of chromosome 9 we name Philadelphia chromosome. That is, researchers show us that it is the often cause of a chronic myelogenous leukemia. Classification. In chronic phase, there are few blast cells in the blood and bone marrow, and there may be no symptoms of leukemia. This phase may last from the several months to several years. Next phase, it is accelerated phase. There are more blood cells in the blood and bone marrow and fewer normal cells. Next phase, it is blastic phase or blast crisis, which is typical for chronic myelogenous leukemia, when more than 30% of the cells in the blood and bone marrow are blasts. You remember, for acute form, it is 80–90% of all cells are blast. Here, for blast crisis, it's 30% of all cells. Blast cells may form tumors outside the bone marrow, give like the equivalent of metastasis. One more phase, it is refractory for chronic myelogenous leukemia. It when the leukemia cells are not decreased even through treatment is given. Chronic phase. If it is untreated, less than 15% of blood cells in blood or bone marrow we can find. It's less than 30% of sum of blood cells and promyelocytes in blood and bone marrow, and less than 20% basophil granulocyte in the peripheral blood. In this case, thrombocyte count usually more than 100. If CML is treated, normal or close to normal blood values without immature granulocytes in the blood. In accelerated phase, what we see? The blast count between 15 and 29% in blood or bone marrow, more than 30% the sum of blood cells and promyelocytes in the blood or blood marrow, and more than 20% basophil granulocytes in the blood. Thrombocyte count in this case, it will be thrombocytopenia less than 100, which cannot explain by treatment. Often also increase in splenomegaly, new chromosome changes in Philadelphia positive clone. In blast phase, I told that it characterizes by level of blasts more than 30% in blood and bone marrow, and patients usually have symptoms of acute leukemia and extramedullary illnesses when blasts migrate to the other parts of organism and can give a new growth patterns. Clinical presentation of chronic myelogenous leukemia. Most patients, it's nearly 90%, are diagnosed during the chronic stage, which is most often asymptomatic and may be diagnosed incidentally with an elevated white blood cell count on a routine laboratory test. It can also present with symptoms indicative of enlargement spleen and liver and the resulting upper quadrant pain these causes. Mild fever and night sweats due to an elevated basal level of metabolism. Some are diagnosed during accelerated stage, it's less than 10%, when fever are most commonly a result of opportunistic infections. Some patients are initially diagnosed in blast phase and in which the symptoms are most likely fever, bone pain, and an increase in bone marrow fibrosis. Here you see typical picture. You can see such picture just in asthenic in a very slim patient, but here it is visible. You see in a line asthenic patient, it is splenomegaly by arrows, it is show enlarged spleen. Diagnosis of chronic myelogenous leukemia. It often suspected on the basis of complete blood count, which shows increased granulocytes of all types. Just CBC can help you to suspect this dangerous disorder. Basophils and eosinophils are almost universally increased. This feature may help differentiate SML from leukemia reaction. A bone marrow biopsy is often performed as part of the evaluation of CML, and CML is diagnosed by cytogenetics that detects the translocation 922, which involves the ABL1 gene and chromosome 9 to the BCR gene in chromosome 22, with resulting in Philadelphia chromosome I showed you on the picture. Thus, CML can be detected by routine cytogenetics and involves gene BCR-ABL1 can be detected by fluorescent in situ hybridization, as well as by polymeric chain reaction. Controversy exists over so-called Philadelphia negative CML or cases of suspected CML in which Philadelphia chromosome can't be detected. Many such patients, in fact, have complex chromosomal abnormalities that mask the 922 translocation and have evidence of the translocation in spite of normal routine karyotyping. The small subset of patients without detectable molecular evidence to BCR-ABL fusion may be better classified as having an undifferentiated myelodysplastic myeloproliferative disorder, and their clinical course tends to be different from the patient with CML. Chronic myelogenous leukemia must be distinguished from the leukemia reaction, which can have a similar appearance on a blood smear, but it is not a cancer. Here you see a microscopic picture, a small hypolobated megakaryocyte. It is big round in the center. In the bone marrow, aspirate typically, that is typical for chronic myelogenous leukemia. And possible picture for chronic myelogenous leukemia, you see on this slide in immunophenotyping. Treatment. The only curative treatment for chronic myelogenous leukemia is the bone marrow transplant or an allogeneic stem cell transplant. Other than these, there are four major mainstays of treatment in CML. Treatment with tyrosine kinase inhibitors, myelosuppressive or leukophoresis therapy to counteract the leukocytosis during early treatment, splenectomy, and interferon alpha-2b treatment. Chronic phase. In the past, anti-metabolism like cytarabine and hydroxyurea, alkylating agents, interferon alpha-2b, and steroids were used as treatment for chronic myelogenous leukemia in chronic phase. But since the 2000s have been replaced by BCR-ABL tyrosine kinase inhibitors drugs that specifically target BCR-ABL and constitutively activated tyrosine kinase fusion protein caused by Philadelphia chromosome translocation. Despite the move to replacement cytotoxic anti-neoplastic standard anti-cancer drugs with tyrosine kinase inhibitors, sometimes hydroxyurea is still used to counteract the high white blood cells encountered during treatment with tyrosine kinase inhibitors like imatinib. In these situations, it may be the preferred myelosuppressive agent due to its relative lack of leukemogenic effects and hence the relative lack of potential for secondary hematologic malignancies to result from treatment. Imatinib. The first of this new class of drugs was imatinib mesylate, approved by US Food and Drug Administration in 2001 years. You know that FDA, it is the biggest and the most important and the most supported organization of drug usage, its safety and its efficiency in the world. Imatinib was found to inhibit the progression of chronic myelogenous leukemia in the majority of patients. It's nearly 65 to 75%, sufficiently to achieve the regrowth of their normal bone marrow stem cells population, a cytogenetic response with stable proportions of maturing white blood cells. Next drugs, it is dasatinib, nilotinib, and radotinib. Dasatinib was initially approved in year 2007 in FDA and treat CML patients who were either resistant to or intolerant to imatinib. Nilotinib also approved in year 2010. Radotinib joined the class of novel agents of the inhibition of BCR-ABL protein and was approved by South Korea in 12th year for patients resistant or intolerant to imatinib. Treatment-resistant chronic myelogenous leukemia. Two approaches were developed to treatment of CML as a result. Both of them in year 2012, and the FDA approved non-BCR-ABL targeted agent like omacetaxin administered subcutaneously in patients who had failed with imatinib and exhibited T315I kinase domain mutation. And in those years, FDA approved a new pan-BCR-ABL inhibitor, ponatinib, which showed efficacy against this gene mutation. Vaccination. Encouraging but mixed results of vaccination were reported in BCR-ABL P210 fusion protein in patients with stable disease with GM-CSF in adjuvant. The median survival time for chronic myelogenous leukemia in prognosis for such patients had been about 3-5 years from the time of diagnosis. With the use of tyrosine kinase inhibitor, survival rates has improved dramatically. In year 2006, follow-up of 553 patients using imatinib showed an overall survival rate of 89 after 5 years. It is a huge survival for cancer patients. And a little bit later, another investigation follow-up of 832 patients using imatinib who achieved a stable cytogenetic response found an overall survival rate, 5-year survival of 95.2. And next time for today, it is chronic lymphocytic leukemia. Let's give definition. What is that? Chronic lymphocytic leukemia, or CLL, is a monoclonal disorder characterized by progressive accumulation of small, mature-appearing, functionally incompetent lymphocytes in blood, bone marrow, and organs. Epidemiology increased by the age. You see that it is increased and reach the peak in age after 65, and male patient are much more sensitive for chronically lymphocytic leukemia much more often than female patient. Classification. It can include stages A, B, and C, and their difference according to number of involved lymph nodes. For stage A, it is from 0 to 2, till 5 it is stage B, and for stage C it can be from 0 till 5. Level of hemoglobin is more than 100 for stages A and B, and it is anemia less than 100 for stage C. Thrombocytes are normal for stages A and B, and it is thrombocytopenia less than 100 for stage C. And middle survival for stage A is more than 10 years, for stage B it is nearly 5 years, and for stage C it is unfortunately just 2.5 years. Clinical presentation. In chronic lymphocytic leukemia, about 40–60% of patients are diagnosed in the absence of disease-related symptoms, even with very high numbers of circulating lymphocytes, more than 100. The presence of lymphadenopathy or an abnormal CBC is only reason to consider a diagnosis. That's why most of these patients are firstly diagnosed by usual follow-up, usual checking with CBC. The remaining patients may present with weakness, fatigue, night sweats, fever, and may be or without infections or autoimmune diseases. Physical examination in physical examination you can find non-tender, painless, and mobile lymphadenopathy, splenomegaly, or hepatomegaly. Metabolic abnormalities like hyperuricemia or mechanical disorders like airway obstruction related to tumor burden may also be present. Manifestation on bone marrow involvement, particularly significant anemia with hemoglobin less than 11 grams per deciliter or thrombocytopenia with platelets less than 100 are noted at presentation in 15 CLL patients. A positive direct antiglobulin test is present in about 20% of patients at diagnosis, but it's not commonly associated with hemolytic anemia. Here you see pictures of clinical presentation of chronic lymphocytic leukemia. On the first picture you see zoster-reform B-cell chronic lymphocytic leukemia illustration. You see such rashes in the patient, and on second picture it is massive adenopathy with enlargement of lymph nodes involving neck from the level of mastoid to the supraclavicular fossa and large nodal masses in both axillary. Diagnosis of chronic lymphocytic leukemia. The National Cancer Institute sponsored working group in diagnosis and response have described a criteria for chronic lymphocytic leukemia. It is peripheral blood should exhibit an increase in the number of small mature appearing lymphocytes to more than 5,000. The bone marrow aspirate smear must show more than 30% of all nucleated cells to be lymphoid. BM examination is indicated primarily to evaluate response to treatment or to access normal elements if there is an unexplained anemia or thrombocytopenia. Here you see microscopic picture. First picture, it is B-cell chronic lymphocytic leukemia, and here you can compare a cell size of chronic lymphocytic leukemia cells with a single large granular lymphocytes. They are curved by arrow. And second picture, it is bone marrow biopsy, shows a global cellularity with a normal range, although somewhat heterogeneous. 3 cell lines present with maturation. And typical pictures for chronic lymphocytic leukemia, what we can see on immunophenotyping. Treatment of chronic lymphocytic leukemia. It focuses on controlling the disease and its symptoms rather than outright cure. Chronic lymphocytic leukemia is treated by chemotherapy, radiation therapy, biological therapy, or bone marrow transplantation. Symptoms are sometimes treated surgically, like splenectomy, removal of enlarged spleen, or by radiation therapy or debulking swollen lymph nodes. An initial treatment like fludarabine or cyclophosphamide or rituximab. Physicians use a watchful waiting mode until the disease progressed. 50% of patients have poor outcome. Since chronic lymphocytic leukemia cells might interact with the stroma in bone marrow or lymphoid tissues, to survive these interactions need to be explored as the targets of innovative therapies. Since as 20% of patients with the worst prognostic markers have stereotypic antigen receptors, they may be valuable points of attack. Prognosis of chronic lymphocytic leukemia. Prognosis depends on subtype. Some subtypes of chronic lymphocytic leukemia have a median survival of 6-8 years, while others have a median survival of 22 years, which is normal lifespan for older patients. Telomere length has been suggested to be a valuable prognostic indicator of survival. Prophylaxis. Patients with leukemia in periods of severe granulocytopenia and thrombocytopenia related to specific anti-leukemic therapies administered demand secondary prophylaxis with antifungals and antibiotics. And abbreviations from today's lecture. That's all for today. As usual, if you have questions, if you have problems or some difficult moment in this topic or in other topics, I wait for your feedback in the comments under the video or for discussion in our Facebook page. See you next week. It will be one more lecture from hematology, and as usual I ask everyone who listen in my lecture to leave your name and group number in the comments under the video. For today that's all, and goodbye.